Okay, so this is grand rounds that Dr. Dion and I put together previously, and I've just been updating it over the years for y'all. But basically, feeding and eating disorders, we usually see these for the most part. I see this with y'all on consults. So what we're going to do is go over some DSM-5 criteria, discuss some of the medical complications, go over the psychiatric treatment, and just kind of look at like some of the media and things like that. I feel like there's so many ways to access media nowadays that's just gotten harder and harder on kids. So some of the history, Richard Morton coined the term nervous consumption in 1689. 1874, Sir William Gall in England and Charles Lessig in France coined the terms anorexia nervosa and anorexia hysterique, respectively. They're describing the symptoms of self-starvation and weight preoccupations associated with anorexia. In 1980, bulimia nervosa was recognized in the DSM-3. So, you know, sometimes I joke around how psychiatry is one of the newest fields in medicine. You know, we basically got our start in the 80s for the most part with good meds and start to diagnose things a little bit more modern. According to the National Eating Disorder Association, 10 million women and 1 million men have an eating disorder. That's been on the rise basically every decade since 1930. And the incidence of bulimia has tripled over the years as well. There's just been a drive for thinness. 42% of first to third grade girls want to be thinner. 46% of 9 to 11-year-old girls are sometimes or very often on diets. 50% of girls between age 11 and 13 see themselves as overweight. 25% of American men and 45% of American women are on a diet at any given day. And this is really appropriate for right now because with New Year's, everybody has a New Year's resolution. And what's part of a New Year's resolution typically, but some kind of diet or something like that. I can relate. I had to go to the grocery store the other day and buy things I didn't know existed, like chia seeds. I thought chia seeds were things you put on this clay thing and made it grow fuzzy as a kid. So there's all kinds of diets out there, all kinds of weight loss plans. And to be honest, I should have put a slide in here that illustrated how big of a business it is too. But this again, you know, 40 billions, right? Pretty big number, but you know, it's not just dieting, there's all kinds of exercise programs that go with these as well. And you know, exercise is really good for everybody too, but everything in moderation, right? 47% of girls in 5th to 12th grade reported wanting to lose weight because of magazine pictures or social media. 69% of girls 5th to 12th grade reported magazine pictures influenced their idea of a perfect body shape. Again, the internet's impacted this exponentially. Actually, believe it or not, TikTok has been a tool in psychiatry. Be it the TikTok tics that are going on all the time that Dr. Lehman and Dr. Phelps are talking about, or catfishing. I'm not saying that y'all should ever go on TikTok, but there is a whole thing of catfishing where if you just put in catfish, it will show you how all these people trick people into thinking they look different than they do in real life. It's amazing that it will take like 2 hours or something like that for somebody to get ready for just like a 1-minute little TikTok thing. And the one that baffled me the most was a woman that had a great deal of cellulite, and you couldn't see her best friend behind her pulling it back in the pictures or taping it back. It's just amazing all the things that kind of go on, but people don't know. So this is going on. And there's just some examples of some pictures of, you know, how people look in magazines after they, the artists get a hold of the pictures. Why is it a problem? Eating disorders have a very high mortality rate, highest mortality rate of any mental illness. 5 to 10% of anorexics can die within 10 years. 18 to 20% of anorexics can be dead after 20 years. Only 30-40% are fully recover, and the mortality rate is 10 times higher than all the other causes of death for females 15 to 24 years old. So that's very concerning. This has changed. Every time I've done this lecture, it's changed over and over again. The one thing that stays the same is the average American woman is about 5'4". When I first started doing this lecture, the average weight was about 140 something, and now it's 5'4", 170. The average American model, however, is about 5'11". That's almost as tall as me. It weighs 117 pounds, which is 100 pounds less than me. And Barbie is 5'9", 110 pounds with a BMI of 16, a bust of 39, a waist of 18, 33 hips, and a size 3 shoe. Do you know what that means? That means Barbie can't walk on her feet. She has to walk on all fours. And I will tell you that, you know, my having a daughter, this has been something I've been very conscious of. And my daughter has never had a Barbie or anything that was body incongruent with reality. You know, she had things like Dora the Explorer or just American Girl dolls, things like that. Never once did she have anything that I thought that she would you know, question how she looked based on it. And I'll tell you, you know, again, you know, it's not nice to experiment on your kids, but when you got, you know, a child psychiatrist, you're going to experiment on your kids. And she's 14, and you know, I'm really happy with how she feels about herself. You know, she's very confident, and nobody's ever told her that she'll worry about how she looks and how she eats. And I feel like that's been really helpful. And it really wasn't that hard. Other things, most fashion models are 98% skinnier than the rest of American women. And I'll say that, you know, some magazines have made some progress. I'll say this, you know, like the, you know, Clemson's terrible at football now, but when we used to be good, I used to get Sports Illustrated, and, you know, they're kind of famous for their swimsuit issue. And I noticed probably over the past 5 years, they've done things in having various different types of models involved, and kind of diversified the population, including like plus size models and things like that. But I've noticed it's also gotten thicker. So I think all they've done is just add extra pages as opposed to shifting it a little bit. Pathogenesis. So it's a combination of genetic, biological, psychological, family, environmental, and social factors. Again, you know, the history of dieting, childhood preoccupation with a thin body, social pressures about weight. Again, like there's a kid in the hospital right now that said, you know, all her friends were worried about weight, so she decided to worry about her weight. Sports and artistic endeavors in which leanness is emphasized, and sports in which scoring is partly subjective, being judged based on their physical appearance. Studies, conflict, sexual abuse, things like that have contributed. Genetics, women with first-degree relatives who have an eating disorder were 6 to 10 times more likely to have increased risk of developing an eating disorder. And they found that there's some genetic linkage between bulimia nervosa and chromosome 10 and anorexia and chromosome 1. So the DSM-5, they really kind of changed things when the DSM-5 came out, but basically anorexia has been the same. That's been pretty consistent. Bulimia nervosa, binge eating disorder, other specified eating disorder, unspecified. ARFID's one of the new ones that we kind of see every so often, the avoidant restrictive. Pica, I feel like we've seen this some on consults, which has been kind of interesting, like the girl who decided she was going to eat all these pieces of metal. That was fairly problematic. And then rumination, we get this one every so often too, some of the younger kids. So there's some screening tests like the eating disorder examination questionnaire, eating disorder inventory, eating attitudes test, things like that. And NEDA has an online screen, and that's the National Eating Disorder Association. And there's a lot of good information on that website. It is the National Eating Disorder Association, but they have some pretty good information on there. Anorexia nervosa, that's just an example of someone that has some anorexia there too. It is more prevalent in industrialized societies. Lifetime prevalence is higher for females than males, but males can have it as well. Criteria: restriction of energy intake relative to requirements, leading to a significant low body weight in the context of age, sex, developmental trajectory, and physical health. Intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight, and distorted perception of body, weight, and shape, undue influence of weight and shape on self-worth, or denial of the medical seriousness of one's low body weight. Restricting type, there's a specifier not engaging in binging purging in the last 3 months. There's a binge eating purging type where they engage in binging and purging in the past 3 months, and different levels of remission. So partial remission, full remission. Mild would be a BMI of 17, greater than or equal to 17. Moderate, 16 to 16.9. So Barbie is there at 16.24. Severe, 15 to 15.9, and extreme would be less than 15 BMI. Distorted self-evaluation. So this is a really interesting, can y'all see my cursor when I do this? Again, okay. So this is how the person actually might look. And this is how they look. But this is what they see. There's a distorted, that they perceive themselves as being much larger than they really are. You know, this girl right here is probably much less than the average weight, but she perceived in this, but she sees herself as still being large. One of the questions I like to ask is, what is your ideal body weight? If somebody tells me their ideal body weight, if they're like 5'4", and they tell me their ideal body weight's like in the 130s, 140s, I don't really worry about too much. If they tell me when they want to weigh 90, then I kind of worry about that. So asking about what the ideal body weight is important. Other thing too about this is there can be some obsessional qualities to it. Again, you know, so everybody knows how many calories are in everything, that kind of stuff. That's important because some of the obsessionality is something that I do treat sometimes with SSRIs. There's not necessarily medication that's great for it, because in anorexia, there tends to not be enough nutrition to actually create the serotonin that you need. But again, you know, addressing some of those obsessional qualities can be helpful with medications, in my opinion. And remember, I love medicine. But the obsessional qualities with medication can be helpful. And then it's also somewhat kind of delusional, you know, if somebody sees themselves as being really overweight when they're not, to me, that's kind of delusional or perceptual issue. And sometimes if you look at up-to-date things like that, medications that treat perceptions and delusions can be somewhat helpful. So when we had the eating disorder clinic here, the Hearth, Dr. Brewerton, who was our eating disorder specialist at the time, he had a cocktail that he pretty much gave everybody, and it was Prozac and Zyprexa. And the Prozac was fairly helpful for some of the OCD type, anxiety type, even anticipatory anxiety with eating. And also the Zyprexa was pretty good for the delusional qualities that you can have as well. And I didn't mention this in here because it's more of a specific consult thing, but sometimes what we will do also when we have somebody that has anticipatory anxiety in eating disorder, sometimes we will actually use like a little bit of Ativan about 30 minutes before a meal just to help them get that meal down or to help them eat. Those are some of the things that we've done in the hospital before. And also in the hospital, it's always worthwhile really getting nutrition and speech language pathology involved in a lot of these cases. Other things you see, it's often associated with depression, so 42%, anxiety, 48%, substance use, 26%, suicide as well, and personality disorders. And we'll talk about some of the personality disorders in the binge eating section. But again, you know, the higher prevalence of depression, anxiety, the problem is, again, you don't have enough neurotransmitter or nutrition for your neurotransmitters to actually make your own serotonin. And that's why it can become a problem. The medications actually don't work all that particularly well. Personality disorders you see with anorexia nervosa are things like obsessive compulsive behaviors, avoidant, dependent, narcissistic, paranoid, and then some borderline tendencies. 56% of patients with anorexia had a lifetime history of at least one comorbid access to serious mental health concern. 34% had 3 or more comorbid disorders. And then there's also, again, you have to be concerned about the suicide rate, 5 times the general population. And these are some of the comorbidities we talked about. Behavioral traits that you see. So again, fear of certain foods, so fear of foods that may be high in calories, restricted repertoire of foods, overestimating number of calories consumed. Again, that kind of feeds into kind of the delusional quality that I see with these sometimes. Overusing condiments or artificially sweetened products, food-related rituals. It's interesting. It always kind of baffled me when I first got into this, that people with anorexia may cook a lot, and that what that is sublimating food without consuming it. So they actually might be a really good cook and might cook all the kind of stuff they want to eat, but then actually don't eat it and they give it away. There will be concerns about eating in public, exercise-related rituals, restlessness, hyperactivity, inflexible thinking, rigid thinking. May be kind of hard to convince folks that they need to address their eating for their health. Perfectionism, the need to control one's environment. Behavioral rigidity, again, purchasing food from only certain stores, certain salespeople, which all this kind of sounds kind of obsessional as well. Presenting symptoms, so things you might see in presentations. So amenorrhea, I think that's one that I think we always think of pretty quickly, but along with that goes things like infertility, exertional fatigue, again, because you don't have the nutrition, weakness because you don't have the nutrition, cold intolerance because you don't have your fat layers that you need. And with the cold intolerance, you can get the, what's that hair called that babies have? Is it lacunae? Is that right? Do I remember that right? I think it's called lacunae.
Lanugae?
Lanugae, that's it. I knew it was something like that. The lanugae. Because you don't have the electrolytes, you can have palpitations, you can have dizziness, again, from lack of nutrition. Abdominal pain and bloating. And where that becomes a problem, the abdominal pain and bloating, is when you actually start eating, you feel much more full than you would previously, just because anything in your stomach can be somewhat of a challenge. So that's why sometimes actually having, instead of giving a bolus, sometimes they start off with like slow feeds. Constipation, swelling of the feet, and irritability. It's a good many medical complications. I think I sent this. Did y'all get this? These slides? Okay, I tried to send them to y'all earlier this time. Obviously, there are a good many there, but cachexia, low BMI, arrested growth, hypothermia, several cardiac difficulties there. There's the lanugo down there. You can have even hair loss, osteoporosis, which makes sense because you're not getting the calcium that you need. GI problems, you can have renal problems, numerous electrolyte problems, and blood dyscrasias. This is somebody with a BMI of 19, and then somebody with a BMI at 12. The BMI of 19 is A and B, where you can see that they actually have internal loss of their fat as well. Other things to consider are things like osteopenia, osteoporosis. Again, this is going to be a lot later down the road, but this is when you're building your bones. Make sure you don't break your hip when you get older. My grandmother, poor thing, broke both her hips when she was older, and she kind of just grew up on a farm that didn't really have that much nutrition information. Refeeding syndrome. This is one of the things that we have to be really cautious of on inpatient. As a result of fluid and electrolyte shifts during nutritional rehab, hypophosphatemia, hypokalemia, hypomagnesemia, and volume overload. We actually had a kid that it was nice. We had a couple of kids that were psychiatrically involved, and it was a lack of eating due to catatonia or demon possession. Yeah, the kid thought, poor kid. It was a really, really long story, but yeah, she was fasting because she was trying to cast out a demon, and that is in the Bible. That's one of the ways you can cast out a demon. But she said that she had Beelzebub in her, and she was trying to cast out a demon. She wound up looking like she had anorexia at the time too. I think her BMI was like in the 14, something like that. Other lab findings: you can have leukopenia, mild anemia. You can have elevated BUN, elevated LFTs, metabolic alkalosis as a result of induced vomiting. I think that's important. I know. Dr. Stallworth loves this one because even when I was a med student, he always wanted me to know that the acid and the base related to this. And metabolic acidosis is also something you can see of laxative abuse. And thyroid, you can have T4 in low normal range and T3 low. Other things, you can have low estrogen for females, low testosterone. EKG can have sinus bradycardia. EEG can have diffuse abnormalities. And imaging can have an increased ventricular brain ratio. Again, you know, what we have to do is we have to have nutritional rehab, medical monitoring, psychological treatment, so things like cognitive behavioral therapy, dynamic therapy, family therapy, and I'll talk about that a little bit more later too. And again, pharmacotherapy, we kind of talk about that, but the fluoxetine is indicated for bulimia, but it doesn't work, you know, it doesn't harm trying to start it at this point if they're able to tolerate it. And then olanzapine is really kind of nice because it does hit the, it works on some of the delusional qualities that you have, but it also is a great appetite stimulant too, to be honest. One of the gold standards, and this might be something I don't know if it would be on the boards or not, but it's Maudsley family therapy, and this is family-based therapy with the Maudsley approach. It basically has 3 phases. It has the weight restoration, returning control over eating to the adolescent, and establishing healthy adolescent identity. And the problem is, again, there's a lot of resistance at the very beginning because the adolescent may not want to gain weight, and they may not have the insight to understand why they need to do that for health reasons. And that's where that loss of control happens in phase 1. That can be kind of hard with the weight restoration part. Family therapy also supports parental management of eating related behavior until adolescent demonstrates improvement. Kids are sneaky, and the parents may not know. You know, the kids might be wearing baggy clothes or something like that, or there's all these websites that tell you how to trick people into not knowing that you have anorexia, like pro-anorexia websites and things like that. Adolescent focused therapy, it's therapy that targets autonomy, self-efficacy in the context of adolescent development. Well, CBT is a CBT for everything. If there's a test question, unless it's borderline personality disorder, CBT is pretty much good for everything. But it's individually focused therapy. It targets the adolescent's management of behaviors and distorted cognitions. And that can be somewhat challenging because some of it is somewhat delusional. But again, you know, the negative perceptions where they perceive themselves as being overweight, or people are judging them, or people are talking about how much they weigh, those types of things, and addressing that. Interpersonal therapy, again, changing problematic interpersonal relationships that can trigger or maintain eating disorder symptoms. Again, just working on the relationships, improving the relationships can improve mood and have an impact on eating habits. Antidepressants, again, they can work on the symptoms of obsessionality, anxiety, and depression, and it targets some of the binge eating and purging and bulimia nervosa. Again, remember, Prozac is indicated for bulimia, and that's 5-HT2C is the receptor that it hits. Zyprexa hits that receptor as well, but that's the main receptor that we use for that. Remember, it doesn't work for anorexia because, again, you don't have the nutritional building blocks. And just a tidbit to just tell you that what happens with serotonin, it comes from tryptophan, which is from protein, but eating more protein doesn't help you get more serotonin in the brain. It's actually insulin that actually helps the serotonin get through the blood-brain barrier. So if you ever get stressed out, who likes chocolate or carbs? Yeah, and that's why. It's actually the insulin that helps the serotonin cross the blood-brain barrier is why we're doing that. And that's why we like some of those things. So again, eating more tryptophan ain't gonna help, but again, a well-balanced diet with your protein and your carbs can be helpful for that. I always wondered that. That was like a wives' tale that I was like, everybody craves chocolate when they're stressed, but and then actually chocolate has caffeine in it too. Something like that, and it just makes us feel good. You actually do get another thing about that too is you actually do get a dopamine spike in the nucleus accumbens when you eat chocolate. Which makes
did we think about who's gonna take care of the animals?
Yeah, I texted Emily.
Emily's taking care of them?
Yeah.
Don't give
She's
animals
got COVID, but she says she'll come take care of them.
chocolate's good for dogs.
Your mic actually.
Cool beans.
Yep. I already spoke to her.
While we're on the subject of chocolate, that I will tell you.
No, I was just rolling on Tabby and I was like, wait, who's gonna take care of my muffin there?
The other thing about chocolate though too is that you will have a really profound dopamine spike the first bite of chocolate you eat. but then you will not get the same bite. You will not have the same spike if you continue eating that chocolate cake. So the first bite's the best, and then the rest aren't quite as good. So if you really want to enjoy it, just have a bite like once every hour, and you'll keep getting the same dopamine spike. So just pace yourself. I've eaten a whole box of Girl Scout cookies Thin Mints before. And my dogs have eaten a ton of chocolate before, and they were fine too. But it's a chocolate lab, so I don't know if that makes a difference. Other things that are going on. Again, fluoxetine is the most widely studied. I love fluoxetine. If I were depressed or anxious, this would be my favorite one. The FDA approved the treatment in bulimia, but the studies were, but the dose for fluoxetine in the studies was higher, typically needed for depression, which is pretty consistent with what you would see with obsessive compulsive disorder. It's almost like there's certain doses for antidepressants. So like, you know, the first third of dosing is pretty good for depression. Then the middle third is starting to get in the anxiety territory. And then the last third of the dosing for antidepressants is the range where you need for obsessive compulsive disorders. Atypical antipsychotics, again, we talked about this, but can help with the body image distortion that you can have. And that's why we use these. It's also helpful for some of the comorbid conditions. Again, it helps with also some of the weight gain as well. So bulimia. First distinguished from anorexia in 1979. Prevalence is about 1.5% for women, 0.5 for men. I don't know if these rates have changed since COVID. It'd be interesting to see. Basically, what you have with that is recurrent episodes of binge eating, with both eating in a discrete period of time. Any 2-hour period amount of food is definitely larger than most people would eat during a similar period of time, maybe like around 2,000 calories. And a sense of lack of control over eating during the episode. And then there's also recurrent inappropriate compensatory behavior in order to prevent weight gain. So again, so you eat a lot of food that tastes really good, and then you have self-induced vomiting or misuse of laxatives or diuretics or enemas or fasting or excessive exercise. And the binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. And I've seen like people exercise like 4 hours a day after having like a candy bar or something like that. What else? Self-evaluation is unduly influenced by body shape and weight, and the disturbance does not occur exclusively during an episode of anorexia or nervosa. Specifiers, so partial or full remission, mild 1 to 3 episodes, moderate of compensatory behaviors, moderate 4 to 7, severe 8 to 13, and extreme is 14 compensatory episodes per week. Comorbidities, again, are things like suicide, anxiety disorders, mood disorders, substance use disorders, and personality disorders. Borderline personality, about 21% of patients with bulimia, avoidant 19%, dependent 10%, paranoid 10%, histrionic 9%, obsessive compulsive 9%. Again, they can have lethargy, irregular menses, abdominal pain, bloating, constipation. Other things you can find, loss of dental enamel, that's one of the things that you look for because of the acid. Dental cavities, enlarged parotid glands, scars on the dorsal surface of the hand from purging, tachycardia, hypotension, dry skin, and hair loss. It's not that uncommon actually though to have folks that don't have the Russell signs because they've gotten so good at vomiting they can do it without even gagging themselves. Other things that you can see, again, electrolyte abnormality is the hypokalemia, hyponatremia, hypochloremia. The metabolic alkalosis comes from vomiting. The acidosis comes from laxatives. And then you can have the elevated serum amylase as well. Again, just medical complications, salivary gland hypertrophy, gag reflex, numerous of GI problems and electrolyte problems. And that's why I say all the slides. Again, things that work for this, again, cognitive behavioral therapy, treatment of choice, because we saw that there were so many other comorbidities with it as well that respond very well to cognitive behavioral therapy. Pharmacotherapy with antidepressants. Fluoxetine is FDA approved, and Wellbutrin is contraindicated. So just remember that. Bupropion is a little tricky because it's good for depression, but it's actually not good for anxiety, and it is contraindicated. Because you're more likely to have seizures if you give bupropion to somebody with bulimia. ARFID is one of the narrow ones, the avoidant restrictive food intake disorder. It's an eating or feeding disturbance with a lack of interest in eating food, avoidance based on the sensory characteristics of food, or concerned about the aversive consequences of eating. Can manifest the persistent failure to meet appropriate nutritional or energy needs associated with. You can have significant weight loss, significant nutritional deficiency, dependence on enteral feeding or oral nutritional supplements, and marked interference with psychosocial functioning. It's not better explained by lack of available food or by associated cultural sanctioned practice like fasting rituals. The eating disturbance does not occur exclusively during the course of anorexia nervosa or bulimia, and there's no evidence of a disturbance in the way in one's body weight or shape is experienced. So again, they don't have those perceptual distortions. It's not attributable to a concurrent medical condition or not better explained by another mental disorder. And then when the eating disturbance occurs in the context of another condition or disorder, the severity of the eating disturbance exceeds that you would typically see. People with autism spectrum disorder are more likely to develop ARFID, and so are the folks with ADHD and intellectual disabilities. A lot of that just has to do with restricted eating or picky eating. Children who don't outgrow normal picky eating or in whom picky eating is severe appear to more likely to develop ARFID. Many children with ARFID also have a co-occurring anxiety disorder, and they're at high risk for other psychiatric disorders per the National Eating Disorder Association. Things you can see are, again, weight loss, addressing layers to hide weight loss, constipation, abdominal pain, big gastrointestinal issues, dramatic restriction in types of amount of food eaten, only eat certain textures of food, fears of choking or vomiting. And sometimes this is precipitated by an actual event. We had a kid with ARFID that got nacho chips stuck in her throat once. And after that, she would only eat soft things. Lack of appetite or interest in food at limited range of preferred foods becomes narrow over time. Again, there cannot be a body image disturbance or fear of weight gain. Consequences are pretty similar to a lot of the other things that we've seen before. Again, cold, dizziness, amenorrhea, stomach cramps, things like that. Again, you can see the dry skin, brittle nails, the lanugo, thinning of the hair, muscle weakness, or wind healing, again, from lack of nutrients. Other specified eating disorder, feeding or eating disorder. A person must be present with feeding or eating disorders that cause clinical significant distress and impairment, but do not meet full criteria for other disorders. And it can be assigned when the presentation does not meet the specifics of another disorder. So things you can have is like atypical anorexia, all criteria met except despite significant weight loss, the patient's weight is within or above normal. And then binge eating disorder of lower frequency. So again, all the criteria for binge eating disorder are met except the lower frequency. Again, you can have things like all the criteria met except you don't have the binge eating. The binge eating and appropriate compensatory behaviors occurs at lower frequency. And purging disorder, recurrent purging behavior to influence weight or shape in the abscess of binge eating. Night eating syndrome, recurrent episodes of night eating, eating after awakening from sleep by excessive food consumption after an evening meal. It's not better explained by things like environmental influences, social norms. It's not better explained by another mental health disorder. And sometimes I actually see this with my kids. They're on stimulants just because of the appetite suppression during the day. Unspecified time means we don't have time to figure out the ER. We know that I got something going on with their eating, but we don't know what it is. And that's when unspecified is supposed to be. Binge eating disorder. Binge eating disorder, recurrent episodes of binge eating. An episode of binge eating is characterized again by eating in a discrete period of time, a 2-hour period amount that is definitely larger than what most people would eat in a similar period of time. under similar circumstances. And again, we talked about how that's usually about like 2,000 calories. So I remember when I was in college, my best friend's girlfriend at the time, she was a KG, I think, at Clemson, and she was so happy. She wanted to bake a cake for her best friend in her sorority, and we baked the cake and everything like that, and then we put it in the fridge, or she put it in the fridge at the sorority. She was going to give it to her best friend the next day, and it was gone. And that happened a couple times actually in the house, and turned out one of her friends was binging on these cakes, and they had a lack of control over eating during the episode. They felt like they couldn't stop how much they were eating. They felt really bad about it, to be honest with you. They can be associated with eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed about how much one is eating, and feeling disgusted with oneself, depressed, or very guilty afterward. This was kind of interesting though, because it takes like 20-something minutes before our brain tells us, or our stomach tells our brain that we're full. But the average American meal is anywhere between like 5 and 8 minutes. We tend to eat really fast. So there's a really big problem with Americans, like overeating. Anyway, that kind of feeds into that. Mark the stress regarding binge eating, again, on average, at least once a week for 3 months, and it's not associated with recurrent use of inappropriate compensatory behaviors like purging. I had a patient when I was at MCG, and she would, on the way home, she would either get a whole hot now dozen donuts and eat it on the way in the car on the way home, or she would get a whole bucket of chicken and eat it on the way home before she got home, and then she would hide that she did all that. There would be notice fluctuations in weight, both up and down, stomach cramps, gastrointestinal complaints, difficulty concentrating. Again, it's actually often associated with obesity and weight stigma, with some yo-yo dieting. Up to 2/3 are labeled clinically obese with binge eating disorder. So this is my favorite part. I love ADHD medications. I just absolutely love it. They're amazing. They make my life so much easier, and you can help people so much. But y'all familiar with Vyvanse? Vyvanse is famous for ADHD, and it's the first FDA-approved medication to treat moderate to severe binge eating disorder in adults. Common side effects are things like dry mouth, insomnia. And one of the things that makes it helpful is a lot of times we can either graze or just flat out binge, and it just really helps with your appetite for 14 hours. It helps with your impulsivity as well, and I think there's an impulsive component to some of the binge eating that we can have. So that's one of the reasons why it's kind of nice, and it makes sense, to be honest too. Other things, there are other medications that can be used to reduce symptoms, things like Topamax is an anticonvulsant, anti-epileptic that has been found to reduce binge eating disorders episodes, and it's not FDA approved, but it's been used for that. It has side effects of dizziness, nervousness, sleepiness, and concentrating. So that's one of the things that's a little bit tricky with Topamax, is it's not best for high achieving academic folks because it can cause cognitive dulling. Antidepressants, again, antidepressants can reduce binge eating, and basically it has, again, like I talked about, how sometimes our moods can influence our eating habits. Psychotherapy, again, things like whether an individual or group session, it can be helpful. CBT can help patients cope better with the issues that can trigger a binge eating episode as well, like negative feelings about the body or depressed mood, and help give people a better sense of control. Interpersonal therapy, again, this works on interactions during the day with other folks that may stress you out, that may lead to binge eating episodes. Dialectic behavior therapy, we're talking about, again, how personality disorders can contribute to episodes. And dialectic behavioral therapy is basically like, you can't go to the grocery store and leave now without a bunch of candy on one side and then a magazine about mindfulness. It seems like, and mindfulness is, of course, a core part of what we do with dialectic behavioral therapy. Dialectic behavioral therapy basically helps us even out our moods, even out our emotions, so that we can cope better and use better coping skills, or use more appropriate coping skills than some that may be harmful for us. It is interesting. We did have that one patient that basically was self-harming with eating. And I thought that was kind of interesting. So it would make sense that dialectic behavioral therapy would be helpful with folks like that. Feeding disorder, again, pica. We've had some folks with pica. Persistent eating of non-nutritive, non-food substances over a period of 1 month. Again, we had that girl that was eating all kinds of whatever she put her hands on. But that was in a self-harm behavior. What can happen with pica often is, which I don't think I've actually seen it too much, but the common scenario is a teenage girl that is eating like paper, or a lot of times like tissue paper, or non-nutritive items that they feel like won't make them gain weight. They'll help them feel full. So again, that's why things like tissue paper and things like that are things that people might eat. Also, I know we've had several cases of pica where the folks were eating their hair. It was trichotillomania related to pica. And what was going on with some of that was anxiety. Other things you may see, again, are things like intellectual disability, autism spectrum, schizophrenia, medical conditions, things like that. And a lot of that has to do is that, the oral phase, some of our patients will get stuck in a phase where they are more oral and want to put things in their mouths. I do have patients with autism that literally have chew toys, and it's very satisfying to them. It helps them a good bit. It helps prevent some of these episodes. First line, again, test for mineral and nutrient deficiencies and correcting those, often concerning behaviors. Disappears, deficiencies are corrected. Behavioral interventions are available if not nutrition related. Redirect the person's attention away from the desired object and reward them for discarding or setting down the non-food item. Rumination, I feel like we get this one every so often. That's repeated regurgitation of food for a period of at least 1 month. It can be rechewed, reswallowed, or spit out. Repeated regurgitation is not due to medical condition, and the behavior does not occur exclusively in the course of anorexia, bulimia, binge eating disorder. Again, what's the physical cause for rumination has been ruled out. Again, you want to use things like, there's some good handouts for rumination, but deep breathing techniques can be helpful, and habit reversal training. It's really hard to find a habit reversal. There's only one person in town I know that does that. I don't think he does too much with rumination, but the deep breathing techniques have actually been pretty helpful. And I've got handouts for that in our little drawer. Orthorexia, we actually had a resident that did a grand rounds on orthorexia. And you all heard of that before? No, it's been proposed to be in like DSM-6 or whatever happens next. It's compulsive checking of ingredients and list of nutritional labels, increased concern about the health of ingredients, cutting out an increased number of food groups, inability to eat anything but a narrow group of foods that are deemed unhealthy or pure, unusual interest in health of what others are eating, spending hours a day thinking about what food might be served at upcoming events, showing high levels of distress when safe or healthy enough foods aren't available, and obsessive following of food and healthy lifestyle blogs. Body concerns may not be present. And then there's a whole grand rounds on this. I have one slide. But basically, it was like these folks that would spend like 3 hours a day preparing their meals, and they would have like all organized these neat little packages and stuff like that that they would take with them, and they wouldn't eat anything else other than the specifics. The American Academy of Adolescent Psychiatry actually has practice parameters for eating disorders, which is really nice. You can go on the ACAP website, and they have practice parameters or recommendations for these disorders. Again, mental health clinicians should screen all child and adolescent patients for eating disorders. So I don't know if y'all read my notes, but usually I try to comment on eating disorders in my review systems, because you never know what you're going to find out. I pick up on it more often than I would expect, to be honest. Like a lot of folks have reported that, that wasn't why I was seeing them, they've dabbled in it. So this is, again, something important for y'all to to ask, and I just ask simple screening questions. You know, you ever do anything unhealthy, lose weight, starve yourself, throw up, those types of things. Over exercise, those are questions that I tend to ask, and it is not usually pretty good to ask, you know, like what their ideal body weight is, and if that's way off, then you might be more concerned. What else? Severe acute physical signs, medication complications need to be treated. Psychiatric hospitalization, day programs, partial hospitalization, residential programs. Those things do exist and should be considered only when outpatient interventions have been unsuccessful or unavailable. That's kind of the hard part. When do we admit these kids? You know, when do they go to the psych hospital? When they're not? Those types of things. So we're happy to help with that. Often a psychiatric hospitalization wouldn't necessarily be all that helpful unless there's a significant comorbidity or safety concerns. And unfortunately, our inpatient units are not able to have things like tube feeds or things like that, or that's why they have to be actually eating on their own to go over there. Usually it involves a multidisciplinary team that's developing aware, sensitive to the skill in the care of children and adolescents. Outpatient psychosocial interventions are the choice for children and adolescents with eating disorders. Again, use of medications, including complementary and alternative medications, should be reserved for comorbid conditions or refractory cases. And I just do some scenarios in here if you want, but sorry, that was a lot of slides. I tend to overdo it, but was that helpful? Do y'all have any questions right now? And I like the spoon feed, that's why I made sure I had all the slides.
With orthorexia, people who avoid pretty like normal food, whether it's fast food or eating out and everything, is that, I mean, consider for the effect of being healthier themselves and then doing all the meal prep and everything, is that orthorexia or is that just healthy eating?
So yeah, so I wish Pete were on here because Pete's worse than me, and probably people think I'm crunchy or something like that the way I eat, because I'm really careful about what I eat. We eat, like, you know, what did we have last night? We had grilled chicken with fresh broccoli and sweet potato, and that was it. And then the night before that we had salmon and broccoli and beans, which is fine. And then the dessert was like fruits. But so the whole thing about the DSM, and there's like a disclaimer in every disorder, and the disclaimer at the very bottom is it should be causing significant difficulties in occupational, academic, or social function. So if you're spending like 4 hours a day getting your stuff ready and you're getting late to work, or you don't have any, you know, it's probably obsessional to the point where it's causing problems for you, like, you know, relationship problems or something like that, that's where that would come in handy. You know, some of the orthorexia ideas would be great for somebody with diabetes. You know, imagine how well your sugars would be controlled if you had people that were so compliant. You know, so and it probably is. You know, there are probably some diets that actually do recommend that. So it should be, again, causing significant problems in social, occupational, or academic arenas. Same thing with OCD. You know, I don't know if anybody y'all have been in my office before, but my office is messy, and it could be a lot cleaner. But you know, if you're spending 2 hours in the morning trying to clean your room perfectly and it's making you late to school or making you late to work, that's when you talk about OCD. You know, so it really has to be contributing to some kind of daily living difficulty.
Makes sense.
I have a quick question. Can you talk a little bit about eating disorders in patients who were not at a healthy weight before? So like an individual that's considered obese or morbidly obese, and they restrict and start exercising a lot. I know a lot of people will be very like in using the BMI criteria, and I know in adults sometimes that number can change with bariatric surgery, but I know sometimes individuals that are at a higher weight, when they develop these behaviors, it's praised rather than seen as pathologic.
Yeah, I would think, I think that'd probably be more on the medical side if, you know, if they're starting to get lab abnormalities and things like that, because, or if they're having physical symptoms because of the rapid weight loss. You know, you can probably have all kinds of electrolyte deficiencies like they're saying, or like fat loss internally that you need, or even like calcium problems with your bones and things like that. So I don't know how fast you can lose weight. That's a tough question. I would think that would usually what these wind up being is if there's medical complication related to it, then it might be too much. Does that sound right, or is that what you're asking?
Yeah, essentially. I can sometimes see like the thin individuals who get thinner, it's seen as they are sick and need treatment. But individuals who are obese or overweight, when they exhibit similar behaviors, it's like encouraged and perpetuated rather than them getting similar interventions and treatment.
Yeah, you're right. There's a lot of subjectivity to it. I think you're right. You know, some person may see somebody like, oh my gosh, I can't believe that. And no, you're right. And again, I think that really kind of depends again if it's causing some kind of impact, like, you know, I suppose I should say academic, occupational, social, and physical impact with that, you know, in a negative sense. Again, the BMI can be all over the place. I think my BMI is like 27 or something like that, but my waist size hasn't changed since I was in high school. So, you know, that can happen. The BMI is just kind of rough. And there's some folks that are just, you know, built more slender than others. There's some people that can eat all day and not put on weight. I think other areas that I didn't mention to be cautious of for y'all that we've seen on consults too is people who play with their insulin, play with their diabetes to stay thin. We've seen that before too. That's something to be kind of cautious of. Anything else? No. Okay. Well, thank y'all.
Thank you, Dr. Getz.
Yeah, I hope that was helpful
Thank you.
for y'all.
Thank
I
you.
want to make sure y'all had all the slides. But yeah, check out the ACAP practice parameters. They're it's like it's really helpful. Okay. All right. Well, y'all take care.
Thank you.